This podcast was proudly brought to you by the Australasian College of Nutritional and Environmental Medicine. Acne is a non-profit medical college offering postgraduate training and education for doctors and other graduate healthcare professionals. This is FX Medicine. I'm Andrew Whitfield-Cook. And joining me on the line today is Rebecca Hughes. Rebecca's been involved in the natural health industry for over 12 years, since completing a Bachelor of Naturopathy in 2003 at Southern Cross University. In addition to private practice, Rebecca has previously acted as a regulator of medicines at the Therapeutic Goods Administration, TGA, and managed a government project funded by the Commonwealth National Health Department and Medical Research Council to create clinical guidelines for health professionals. She has also peer-reviewed naturopathic academic texts prior to publication and authored 4 chapters for the current edition of a popular reference text, Herbs and Natural Supplements, an Evidence-Based Guide, which is a seminal book that every natural health practitioner should have in their clinic. Currently, she balances her client time with teaching in naturopathy and nutrition bachelor programs at Endeavour College of Natural Medicine, Melbourne. In late 2014, Rebecca conducted a clinic-based prevalence study measuring the prevalence of metabolic syndrome in a standard clinic population. The results of this study were presented at the 2015 NHAA International Conference. Rebecca is particularly passionate about helping people with acne from her own personal experiences with this as a young adult. Now a naturopath specialising in acne treatment and other skin conditions, Rebecca is having incredible results treating acne sufferers by addressing the hormonal causes of the acne and is dedicated to returning self-confidence to teens and adults. Rebecca, welcome to FX Medicine.
Thank you, Andrew.
I've got to say, I am extremely impressed by your acumen, but also your care, because, when a practitioner has a certain condition, that personal experience, it really builds a fire to become expert in it. And I can see that you have done that because I've met you and you have an extremely beautiful complexion. So it's obviously worked. So I guess first, tell us about your background and why was it, apart from this personal journey, why specialise in skin? What was it that attracted you to it in naturopathic care?
Well, I think sometimes things and areas of clinical practice choose you. I'm not sure that you always get the benefit of choosing them. And I originally I was seeing a lot of children with eczema and then adults with eczema as well, with really chronic eczema. And I suppose that started to develop my interest in treating skin conditions. And of course, I did have my own personal experience with a skin condition as a young person. And it wasn't until I started treating a couple of people with acne that I saw that actually it's not, it's easy for me. It's easy for me to treat acne, but it's also, it's such rewarding work. And I just really want to thank you for giving me the opportunity to speak about it today, because acne has been recognised as a chronic disease, and the mental health impairment scores for acne sufferers are as high, if not higher, than for psychiatric or conditions or chronic diseases like epilepsy and diabetes.
Wow.
It's an enormous effect on people's mental health as well as their physical health. They have higher rates of depression, anxiety and suicidal ideation. And they have higher unemployment rates than people without acne. So the effects are far-reaching. It's not just the skin condition, and that's why I really love treating it, and I really want to give people a sense of, I was going to say hope, but hope even seems insufficient, that actually there is a solution to their acne, and there's a solution without the use of what I believe to be fairly harmful prescription pharmaceuticals that are generally used to treat acne.
Yeah. Well, they're pretty well known to be harmful, particularly in certain populations. But what I find is really interesting is I met a dermatologist, and one of the standard frontline prescriptions for acne is low-dose antibiotic, working as an anti-inflammatory, not so much an antibiotic. Now, that's in an infective situation, i.e. it doesn't reach a minimum inhibitory concentration, an MIC. That is not to say that it's not wrecking your microbiota, which is another argument totally. But what I thought was interesting is this dermatologist was actually saying, oh, no, I don't like the use of long-term antibiotics because blah, blah, blah. And I'm going, what? Where has this awakening come from? It's really strange.
Yeah.
But that really amazes me. I do remember, my old nerdy, uncomfortable, angsty high school days, and I had acne, and I was a shocker for picking them, and I remember the inner dialogue, and I by no means did I have the worst acne. There were people with much more cystic acne than I, and I understand that real judgment that people have. Because it's the first thing you look at. As a species, you're identifying as one of your own species. And when you see a wolf or a human, and you see that human who looks different, you want to analyse it to make sure everything's okay. So I can fully understand that would really play havoc on one's self-esteem.
No, that's just why I do what I do. It's not just, obviously it's to get rid of, you want to resolve the acne, but it's really what the acne is causing in other spheres of life that is actually the impact. Sometimes there's pain associated with the acne. Not everyone has pain, but some people have pain.
Wow.
But it's more the psychosocial, emotional impacts that concern me.
So take us through the different forms of acne, because I'm going to sort of guess here that there's a lot of interplay.
Okay, well, I'll talk about the different presentations.
Presentations, sorry.
And some people have fairly superficial lesions where it's mostly papular or pustular, and that's the extent of the depth of their acne. It still can be quite diffuse, like it can be, all over their face, or you can get papular pustular acne on chest. It's very common as well. And then I would say the next level in severity of acne is nodular acne, which is, I suppose, commonly called cystic or hormonal acne, where the lesions themselves are much more inflamed and enlarged, and they take much, much longer to resolve, and they can leave greater scars. And nodular cystic acne, I'm not going to say absolutely, but typically it appears to be around the lower area of the face, the jawline, the neck, and shoulders and back. That tends to be the location of that type of acne. And then there are acne severity rating scales. There's various different rating scales based on the number of comedomes or lesions, and that's more used, I guess. Those severity rating scales are used a lot in clinical trials to determine selection of participants in trials. There are two more conditions that start with the name acne, so acne rosacea, which isn't really related to acne vulgaris. So acne vulgaris is the one that I previously described. Acne rosacea, look, the jury's still pretty much out on what the pathophysiological cause of acne rosacea is, but that tends to affect more so blood vessels, and they can be small pustules that are associated with acne rosacea, but it's certainly quite distinct from acne vulgaris. And then there's another condition called acne inversa, and it's probably called that because the full name is really long and complicated, which is hidradenitis suppurativa.
Yes,
and
yes, it is confusing.
And they are. They're large boils that appear mostly in the genitourinary area, in the groin, and can be in the armpits as well. And suppurativa meaning that ultimately they burst and suppurate, and so they're highly inflamed, painful and infective and can leave very large scars. And that that condition isn't related to acne vulgaris, but I guess it was, likened to acne because of the suppurating nature of it. But it also comes with its own degree of, as you can imagine, psychosocial impact and sexual dysfunction because of
absolutely.
the location of the lesions.
Yeah. So can I briefly ask, I know this isn't the main point of our topic, but acne inversa, pathophysiology, is that an infective agent or an immune-mediated disorder?
It's multifactorial, and I think the traditional pharmacological treatment gives you an indication of that. And it's some fairly, again, heavy-handed pharmacy that's used, like immunosuppressants, so chemotherapy, essentially, and prednisolone and long-term antibacterials. So that type of medication is used. Having said that, I don't know that people with acne inversa seek out naturopaths. I think they should, because I've only treated one patient with acne inversa, and I got a really fantastic result with quite a foundational naturopathic approach, let's say.
Yeah. Wow.
So I don't think, again, and because the ultimate treatment in acne inversa is actually surgical, which is extremely invasive. Extremely invasive, but probably more concerning is the use of immunosuppressant therapy, I think, because it comes with its own. Yeah.
Yeah, absolutely. So back to acne vulgaris. Take us through the underlying pathophysiology, the underlying factors.
Well, it is. I think it's a multifactorial disease that does have several risk factors. Now, it's a disease of the pilosebaceous unit, which is a fancy name for the hair follicle, basically. And the hair follicle has a sebum sac attached to it. And what happens in acne, in any kind of acne vulgaris, is that there's a hyperproliferation of keratinocytes that forms a plug combined with the sebum of the hair follicle, and that forms a nice environment. Well, it becomes inflamed, and then the inflammation may or may not become an environment for bacteria, and essentially, and so then it can become a nodule or a pustule or a papule, depending on the severity of the inflammation and infection at the site. So that's what happens, essentially, structurally. But in terms of what causes that to happen, I think that there are many factors that cause that to happen, and I also don't think that they're the same factors in every single person who has acne either. And unfortunately, I think that's the way it is treated, that all acne is the same. And there's plenty of literature about Propionibacterium acnes, or P. acnes, as the causative agent, hence the long-term antibiotic therapy. But I think that's an overly simplistic way of regarding the human microbiome, because the microbiome on the outside of our body is just and equally as complex as the microbiome on the inside of our body.
Yes.
And I think P. acnes constitutes less than 6% of the microbiota on our skin. So if there is an imbalance in the populations of P. acnes, then I think the question to ask is why is there an imbalance of that bacteria on the skin?
Yes.
And I think one of the issues with acne sufferers is that there's a tendency to over-cleanse and over-wash, and particularly with antimicrobial agents. So that would be causing an imbalance of microbiota. But P. acnes is considered to be a commensal bacteria when it's in normal populations, but I think it's when it exceeds that limit that it's considered to be pathogenic. But that's the same with many bacteria.
Well, yeah.
So, yes. The bacteria is there, and it is considered to be one of the causative agents, but there's also what causes there to be excess sebum production. Well, that can be androgens, but androgens can be activated by, as I saw in one there's a very, very good paper published recently, dietary glycemic factors, insulin resistance and adiponectin levels in acne vulgaris. And it's probably one of the more convincing papers around glycemic index and glycemic load and its effects on acne.
Yeah.
Because prior to this, there have been a number of reviews done, but they've all been inconclusive, saying that there's really nobody could really say when they combined all the data that there was any impact of diet on acne. But this paper showed that irrespective of serum glucose, serum insulin, insulin-like growth factor, with all those being the same between the matched controls and the study participants, that glycemic load and glycemic index diets were higher in the acne group.
Right.
Now, it was a small cohort. It was only 50 people of acne sufferers. So I think that, you'd need a higher powered study to really show that was interesting,
yeah.
I thought. But at the same time, having treated quite a few people with acne by now, I would say, again, it's not absolute. I have patients who I treat who have better diets than I do, and I'm a naturopath and a nutritionist, and they have the cleanest diet and lifestyle and still have cystic acne. So I don't think you can sort of put all people into the same box, so to speak.
And this is the problem with medicine when you're looking at a population level is it's kind of like saying probiotics for antibiotic-associated diarrhea generally fail. But then, well, that's probiotics, not probiotic, not strain, not species, there's no delineation. It's probiotics. So, Jason Horlak will argue that vehemently, that it's strain-specific. You can't necessarily say the attributes of one or the successes of one strain would negate the failures of another strain and end up with a generally positive aspect on any sort of given. Now, that's in probiotics. Take acne and you've got all these multifactorial issues going on. How do you then tease that apart and lump them all together and say, see, it's not related to diet? Because I remember this argument I think it was in Medical Journal of Australia, and they were saying diet has no part to play in acne. Boom. And then not 1 month later, sorry guys, diet is important in acne. It was seriously within a month.
Well, and I think what I've been exploring in my clinical practice is the hormonal drivers for acne, because most acne happens at adolescence.
Yeah.
It starts during that time, or if it doesn't start during that time, it happens during another pivotal time of hormonal development in someone's life. And you can probably only say that for women, because for some women, their acne only starts maybe post-pregnancy.
Right.
That's another time in a woman's life when acne can start. It's usually much more transient. But I think when you can identify that the acne has started during hormonal development, has cyclical aggravations that are coincident with the menstrual cycle, may or may not be relieved by the oral contraceptive pill. I think you can safely say that there's a hormonal driver at play, even if you don't know what the hormonal driver is. What I've been exploring as one of the primary tools beyond the foundational naturopathic treatment, and I can talk about that in more detail as well if you like, but I've been using urinary dried hormone testing as my main tool, and for identifying exactly what those hormonal imbalances are. And I've found it to be extremely specific and an extremely valuable clinical tool, because once I've done the foundational work, then I can really hone in on what precisely is driving this situation. What is the hormonal imbalance and how can I correct for it? And that's what's getting the lasting results.
Okay. Can I ask you a question on that hormonal measurement? Are you measuring hormones in the system, as in production, or are you measuring metabolism on biotransformation? And indeed, you can go back into reabsorption there, I guess, the interplay of the gut. Which one are you measuring?
Metabolism and biotransformation.
Gotcha. So you're looking at the hormonal, but specifically the estrogen metabolites.
I'm looking at estrogen metabolites, testosterone metabolites,
Oh, wow.
and surrogates for progesterone, because progesterone itself,
Yeah, transfers
there is
into
no,
other things.
and it's particularly useful. And these are the patients that come to me with their blood test results and say, the blood tests have been done, see, there's nothing wrong. It's all normal.
Yeah, it's all normal, quote unquote.
Yes.
Depending on if you're looking right rather than left.
Yeah. And I'm finding, and look, these test methods were developed originally to predict, I think they were originally developed to detect breast cancer risk.
Yeah.
They were looking at estrogen metabolites, 16-hydroxy and 2-hydroxy ratios as a predictor for breast cancer. But I think that they can be applied in many areas of reproductive life, not just whether someone's at risk of a hormone-dependent cancer or not.
Yeah, I think we've got to pay homage to the job of estrogen, and that is to proliferate. And so it's great for skin to make it plump and plush as long as it's controlled well. It's great for fertility. It's great for bone and cardiac health as long as it's metabolized right. And it's protective as long as it's metabolized right. So, I mean, I'm really interested in the hormonal metabolism aspects. I think it was at least one of the early players was H. Leon Bradlau and Firestone. There's a few others, but Eleanor Rogan, I think, came in a little bit later. But there's quite a few of these early players. What was the other one? Zoo and Connie. I'll always remember these guys.
Sure.
But they looked at a myriad of these estrogen metabolites in, I think it was Carcinogenesis 1998. Yes, I am weird. But there was still conjecture as to how relevant it was to predict breast cancer, given that there's so many other players in the causal sort of in causation of breast cancer. But I think it's really interesting what you're doing, because you're now looking at detox. So you're now looking at how the body handles things once they've done their job to get rid of them. So that's very interesting.
Yeah, which is why the beginning of my treatment is generally all about how are the organs and systems like lymphatics, digestion, liver, gallbladder, kidneys, are they all doing the job that they should be doing?
Yeah.
And how's the health and the integrity of the digestive system? Is there inflammation? Is there dysbiosis? There is, and I've got to say, like, there's a lot of dysbiosis in people who have acne, because almost all of them have at one point done long-term antibiotic therapy.
Yeah.
It's very unusual to find someone who comes to me who hasn't gone part or the whole way down the orthodox route. And I really wish people would come to me first, so that I didn't have to do all the corrective work, because then I have to correct for a lot of damage that's been done, as well as support normal, healthy detoxification and metabolism.
Yeah. So can I ask you a question there? Do you find that the 14 species that we have available as probiotics in Australia, and given that most of them are based, not all of them, but most of them are based on milk products, that's sort of where this premise of probiotics sort of came from. Do you find there are enough?
Enough for?
To help correct dysbiosis? Or do you have to employ plant-based material in diet and indeed herbs to help correct dysbiotic pictures in people with acne?
Oh, I almost always prescribe prebiotics at the same time, either in, like, I might do it in medicine for the first few steps to make sure that we get, I mean, ultimately you want the best value out of your probiotic.
Yes.
So you want to be having adequate prebiotic sources as well as probiotics. And if the diet quality is quite poor, then I might supplement with prebiotics until I've done the educational work to improve diet quality. And so I just use, simple things that might be like, guar gum, slippery elm, pectins, things like that. They're they're pretty basic.
Yeah.
And in combination with the probiotics. But I also use, not that this is related to dysbiosis, but it's more about digestive integrity. I also use lactoferrin if there is significant inflammation. And you can tell, because some people's acne is, and this again, it's looking at the presentation and not treating it all as the same. Like some people's presentation is highly inflamed. Like the acne is really red, and in fact all their skin is really red, even the areas that don't have the acne. And so it's obvious that there's inflammation present, and when there's that degree of inflammation present, you can extrapolate and say that, well, the digestive tract isn't, doing as well as it could.
Yeah.
And then for some people it's not, so I may not use lactoferrin, because lactoferrin it's a reasonably expensive product, so I don't want to use it with everyone if they don't need it. Mm. But if there's significant inflammation, then I use lactoferrin and maybe Saccharomyces boulardii. But if there's not, then I'll focus more on large bowel health and ensuring that there's adequate digestion, because I do find that there are some papers actually linking, there's sort of this whole of theory, gut, brain, skin theory, and saying, I think I read a paper that, and it was not looking just at acne, but all seborrheic skin conditions, and saying that I think they estimated that about 2/3 of people with seborrheic skin conditions had a pre-existing or concomitant digestive disturbance. Like, for example, irritable bowel-like picture. And I think it was in a Chinese population, but it was about 20,000 people that they surveyed. So it was a good cohort. So that there is possibly some, something linking, digestive health fundamentally with acne.
Yeah.
But again, as a naturopath, I don't make absolutes.
Can I ask though, I've had rather dramatic results of using cold colostrum with vulvovaginous candidiasis and bacterial vaginosis. Now, given that that's the other end of the body, and given that you normally, unless you've picked the pimples or the acne, there's normally a layer of skin on top. Have you ever used things like lactoferrin, probiotics, or indeed colostrum topically?
No, I haven't used them topically, but I'm keen to. I'm very keen to start using probiotics topically. There aren't a lot of there's nothing really available in Australia as a skin, that's been formulated as a topical preparation.
Yeah.
But there are overseas.
Yeah.
There are internationally, and I'm keen to start using that.
Cool.
Because even in 1930, there are a couple of dermatologists called Stokes and Pillsbury who, all the way back then, they were the ones that sort of came up with this gut, brain, skin theory, and they started using and supplementing with just, not even strains, just species of lactobacillus and bifidobacterium and cod liver oil. Can you believe it?
Really? Wow.
And they were getting great results, but unfortunately, when they were doing this and developing this theory, it was during a particular trend in dermatology away from autotoxicity. Yeah. So they just weren't given any airtime, really.
Right.
And so they were using that, and apparently there's a strain in most yogurts. The second part of it is Thermophilus.
Streptococcus thermophilus.
Yeah, that increases ceramides when it's applied topically.
Ah, right.
Yeah, so you could get your tub of yogurt out and try it on your face.
Well, it's just, this is one of these things, we find these old grandma's tales. This is the thing that I say a little bit glibly, but with some air of meaning, and that is these old wives' tales only remained old if they worked. Otherwise, they wouldn't get told again.
Exactly.
Now, I was going to ask you about creams with regards to, or topical treatments with herbs. Do you tend to sort of favour tropo-restorative herbs, or do you use astringent type things like witch hazel at all? Or, what do you do there with treating acne?
Do you know, I use very, very few topical applications.
Oh, right, okay.
I use barely any.
Yeah.
I mostly treat internally. So
Okay.
I treat with herbs that have depurative, alterative, hepatic, lymphatic actions.
Yep.
So things like, Berberis aquifolium, Actium lapa, Rumex crispus, Gallium aperine, Phytolacca decandra, Echinacea calendula, those types of actions that I'll use internally to enhance all of those organs of detoxification that I talked about before. I will use reasonably high dose vitamin A and zinc to enhance innate immunity and also to speed up skin healing time, because both of those nutrients are important for new epithelial growth. And let's face it, people with acne don't want slow epithelial growth. They want fast epithelial growth and repair.
Yes. Now, this is an important point because it seems counterintuitive, doesn't it? You see a tumorous type look and you go, ooh, inhibit that, and yet, vitamin A can help to slow down the hyperproliferation of certain disorders when it's used in massive, massive amounts. But indeed, you use vitamin A and it has other actions as well.
Well, yeah, it has actions on innate immunity. It reduces sebum production, and it helps build new skin cells, new healthy skin cells. So it also is important for rebuilding digestive integrity. So zinc.
Yes.
So it has a beautiful dual action.
Yes.
And in terms of topical, I find mostly people are already putting too much stuff on the outside of their skin already. Usually it requires me taking things away and saying, okay, maybe stop using the antibacterial soap on your face, or stop using Proactive, or, whatever they're currently using. And I might refer them to someone, like I have worked with dermal therapists in the past, or, beauty therapists who actually just specialise in treating acne. So there's a couple of people I work with. So I may do that, but I find that there isn't necessarily, I could use things like calendula creams, for example, just to soothe the area.
Yeah.
Sometimes I use, there's a little bit of evidence that Chinese licorice and coptis are quite good for the anti-inflammatory, but it's working on that antibacterial theorem. And I've got to say, and I think it's probably pretty evident from the way I speak, is that I'm just not sold.
Yeah, I'm with you.
That it's to do with it's like, this individual just has too much Propionibacterium acnes. That's the problem.
Yeah. Rebecca, what about toxins? We've spoken about hormones and they can be a toxin, but what about things like the POPs, the persistent organochlorine pesticides, and other toxins?
Certainly I do take note of my patients' lifestyles, what their occupations are, what their occupational exposure is, where they live, etc. And, we try and clean that up as much as possible. Now, some of my patients are adults and are highly coachable. Some of them are teenagers and want to be teenagers. So there's also the balance of what stage of change your patient may be at. I almost always encourage all my patients, whether I'm treating them for acne or anything else, to be eating an organic diet, so at least that they are reducing their exposure to those types of chemicals as much as possible. The test that I do does test for bisphenol A, because it's a known fairly potent xenoestrogen.
Yep.
So I think that's very helpful, but it doesn't test for any others.
Yeah.
And normally I find that people who are within range, I only just had a patient recently who was disturbingly well outside the range, and she's a hairdresser, so I suspect it has something to do with the chemicals that she's exposed to at an occupational level daily.
Yep.
But I'm yet to figure out where it's coming from in her lifestyle, that really high bisphenol A, because that's disturbing.
Yeah. Yeah. And what about things like skin types? We're well versed with skin types with regards to how well we're going to metabolize vitamin D in exposure to sunlight. We're well versed with skin types with regards to skin cancer risk. But what about acne?
Yeah, I think it ties into genetics, but genetics at the hormonal level. And almost always when I take someone's case history, they may or may not have a relative with acne, but there'll be some sign of another hormonal disturbance. For example, recurrent miscarriages, infertility, prostate disease or breast cancer. So there's some indication in their family of a trend toward a hormonal disturbance. And of course, constitutionally, that will show up in different people in different ways.
Yep.
And that's why I don't like to. The reason why I test is because I don't like to assume what the imbalance is, and I think there's definitely, and it's pervasive in the literature, that all hormonal-dependent acne is androgen-driven.
Right.
And it's all related to polycystic ovarian syndrome,
right.
and it's androgen-driven.
Right.
And the tests of the patients that I've done would indicate that that is not the case. It is not the case. And in fact, I have women who have high estrone at the same time as having high testosterone.
Oh, okay.
And so I work on both of those pathways at the same time.
Right.
And I can even test for cortisone and metabolite. Like I can test for cortisol and metabolize cortisol as well, which is also valuable because one of the risk factors that we do know is that stress activates localized androgens because there's androgen receptors in the skin, and then that increases sebum production.
Right.
So looking at what someone's cortisol picture I find is also kind of handy because you don't always, some patients are very, very adept at presenting as cool, calm and collected when that's not what actually is happening.
Yeah, yeah. The silk iris.
Yeah. And yeah, so that's why I can't remember if I've answered your question or not, but that's why I find the testing very valuable.
I think the lesson I'm learning from you is stop assuming that you think it's all one, that, we've really got to individualise treatment. And I've got to say, it's really impressing me. So I've got to ask, what about if you're talking about a localised stress response in the skin, couple of questions from that. Sweating. Some people say sweating is really good because it's an excretory organ and therefore it's good. And yet I've seen acne that has been really exacerbated by sweating. But I wonder about the type of sweating.
The other thing is, though, also some people get acne their acne gets worse. So they've already got acne, but their acne gets worse in locations where there's clothing rubbing in a particular place. So, for example, caps.
Yeah.
Caps across foreheads, I notice, is a place where in men, that if men would tend to wear caps more, that their acne can become worse in that location. And because they might be wearing a cap while they're playing tennis or something, for example. And so there's perspiration and oils and friction and heat at the same time. So I guess it's just, your typical inflammatory response, but the thing is you're aggravating an area that's already aggravated.
Yeah, yeah.
So that might be the answer to that. I'm not sure. And I suppose if lymphatics and hydration would play a big part. So I do think perspiration is good and movement is good for anyone who has a skin condition because, of course, the lymph doesn't move itself. The lymph needs you to be active for it to move, and it also needs you to be well hydrated.
Yep. And
I think both of those factors are very useful for people who have skin conditions because the lymph serves a function. It serves a function of removing debris and waste, but it's also part of our immune system as well.
Absolutely. What about, therefore, when somebody's got that, cystic acne on the middle of the cheek area, what about mobilising? I'm not necessarily formalised massage, but just mobilising that area. Does that help in any way, or is there no great, measurable benefit there?
I can't see that there would be a measurable benefit because you might actually aggravate. Now, having said that, quite a few of my patients do go on their own accord to have what's called an extraction facial. And an extraction facial is exactly what it sounds like. It's where comedones are removed, but at least, look, I'm not opposed to them because at least they're done under sterile conditions. So the person who does them with sterile instruments under sterile conditions. And most people with acne will pick their acne.
Yep.
And they won't do it under sterile conditions. And they'll trauma the area by squeezing and pushing and, doing whatever else they can to try and get to remove the comedone. Whereas I figure if they're going to do it anyway, they might as well do it in a controlled environment.
Yeah, yeah. We've spoken about movement, and if you talk about the microbiota, we know that exercise influences our microbiota. It's not just diet; it's also this movement sort of thing. How important do you find these practices are?
It's interesting because a lot of the people who come to see me are already reasonably active.
Uh-huh.
I have to say, so they're already reasonably active. I tend not to have to prescribe that, to be prescribing movement.
Yep.
I find the area that I have to focus on a lifestyle perspective, particularly with some women, is anxiety and stress management.
Right.
I find it a much bigger player, not just in their acne, but in their overall health and well-being. But, yeah, like I said, cortisol is going to increase sebum production, but it also does have an effect on our microbiota as well, and then our microbiota runs us.
Yeah.
So if you're not managing that side of things at the same time, then I suppose you're only going to get maybe the results won't be as long lasting if there's still that background of anxiety and stress. And sometimes the anxiety and stress is directly related to the acne and someone's appearance. It can be directly related to that, or it might be related to their occupation, for example.
Yeah.
If they're in a stressful job. So that's what I find I usually am recommending is, things like yoga, mindfulness, meditation, adequate sleep.
Yeah.
I think the entire Western world doesn't sleep enough.
Yes, that's right.
Yeah. So it's just those fundamental foundations.
And, of course, a fundamental foundation, you mentioned it before, hydration. I remember this example, and it was only an anecdotal report, but with photographic evidence, given that there's some issues around how people light a photo and things like that. But it was a very interesting story, if nothing else. And it was a lady who, I think she saw a psychologist. And
was that in The Guardian?
Yes. And
I saw that.
Yeah, so I mean, this was a very interesting story, if nothing else. And the psychologist said to drink a bucket load of water. It was 2 litres a day, wasn't it?
Yeah, at least minimum 2 litres.
Right. And of course, the woman reported, or the practitioner reported, a dramatic improvement in their complexion. What do you think about that as teasing that out from an anecdotal onto what you see in patients?
Well, I mean, water is required for everything. It's required to make bile and have good bile flow, and then good bile flow and liver function removes hormones, it removes other metabolic waste. Water fills up the lymph, and the lymph is required for removing waste. It cleanses the kidneys. So we're talking at a really naturopathic sort of level of
physiological level.
How water is required for everything. So I think if someone isn't adequately hydrated, and I do tell my patients this, and it's a good way to get them to be compliant with water, is they go, I'm going to give you herbs that are going to enhance detoxification. If you don't drink enough water,
it's coming out your skin.
You're going to get an aggravation of your acne. So they become highly motivated to drink 2 litres of water a day because they don't want their acne to actually get worse. But it could happen.
So do you advocate 2 litres?
Oh, I don't want less than 1.5.
Right, gotcha.
Yeah, I usually say 2 because I know that there'll be days where they don't have 2 and then they might hit 1.5.
Yeah.
And then that's adequate. It depends on their level of physical activity though, because some of my patients are really physically active, so they're quite athletic, in which case I think their water requirement's higher.
Yes, sure.
But the stratum corneum, the very, very outer layer of your skin, needs both water and fat. And in fact, over exposure to water, so over cleansing, showering, washing, etc., removes the water from the stratum corneum. And so it actually reduces hydration in the outermost layer, which is why I try and discourage all of the crazy skin washing that does happen with some acne patients, because they've been told that it's due to bacteria and too much oil, and to wash away that oil, whereas really that oil layer is just as protective. And I think that's another thing that gets missed, is the need to actually have adequate oil and water hydration.
So just in wrapping up, there's two sort of, I guess, base traditional acne treatments. And one of them is the actual essential fatty acids, and the other one that I'm thinking of is the minerals, or the combinations. Zinc, B6, magnesium helps hormonal metabolism, but just zinc on its own is one of the old fames, for acne, with varying degrees of success. How useful do you find them, and what dose do you use?
Zinc I find incredibly useful, and particularly I think in anyone who's had a chronic skin condition, whether it be eczema, acne, psoriasis. Zinc is I think of zinc like iron, like it gets consumed and it gets stored and then it gets utilised. And if someone has had a chronic skin condition, they've had an increased requirement for zinc for a very long time, because they've been building more skin cells than a healthy person. They've had to keep up. So I find most of the people that I see are zinc depleted, and that's fairly obvious usually from their immune health,
Right.
if not from their skin health.
Yep.
Like, they tend to also be predisposed to opportunistic infections, and that tells me that, that zinc is depleted. And so I usually prescribe between 25 and 50 milligrams.
Elemental.
And, yeah.
Yep.
And in a divided dose, typically, because I find not a lot of people can handle 50 milligrams in one dose, because it can make you feel a little bit queasy.
Yep.
But zinc's also useful. It's useful for immunity, skin health, and also for releasing vitamin A from the liver. There's a zinc-dependent enzyme
Yes, right.
that helps release your own vitamin A from the liver. So that's also the dual, again, benefit of taking zinc.
Right. That's very useful. Well, you need to write a book, because this is brilliant work that you're doing.
Yeah, look, maybe I do, because I think I am very concerned about how people with acne are treated in the common medical model and it's not anyone's fault. Like, I'm not demonising doctors or specialists, but there really is just sort of one pathway available to people at the moment, which is, they go to their GP because they're concerned, and their GP either refers to a dermatologist or starts prescribing themselves. But generally the pathway is the same, which is antibiotics, Roaccutane, which comes with its own raft of well-known side effects.
Yes.
And the oral contraceptive pill if you're a woman.
Yeah.
And that's the pathway. And I have to say it's unsatisfactory. And it's unsatisfactory for people, because then they come to see me because it hasn't worked. It's unsatisfactory because of all of the side effects associated with those medicines, both short and long-term side effects. Yes, and it's unsatisfactory overall. And I'd say, look, I'm going to be so bold as to say that it actually isn't evidence-based. Like, even with Roaccutane, when you look at the trial participants in those initial Roaccutane or isotretinoin, is that how you say, trials, they were people with moderate to severe acne. And that's what they're re-looking at all of that data now, because they can't understand why people with mild to moderate acne aren't experiencing the same benefit. Because the trial participants were completely different So, of course, they experienced an improvement because anything would have been an improvement if you had severe acne.
Yes, that's right. Rebecca, I've got to say, I love the way that you've taken what is very often a confounding condition to treat, and it really affects people's psyche, their self-confidence, not just short-term but long-term as well. But the thing that I love is that you've taken something that a lot of people would go, oh, we have to do these really complicated things, and you're doing it with the naturopathic foundational treatments. And I love it. You know, you're not treating so much the acne as the person in front of you. There, I think you've done extremely well on this, so very well done to you.
Thank you. Thank you very much, Andrew. And yeah, I just really want people to be left with that there is an answer, and it doesn't have to be the answer that is routinely presented to them, but there are other opportunities for solving acne and solving everything else that goes along with it, with the, you know, you've already touched on it, the self-confidence and anxiety. And I think if you've never had a skin condition, you're not really present to how it can be, how it can be personally. Like, it's a very personal thing to have a chronic skin condition, in particular acne. And I think there is a lot of judgment out there. I think people go, oh, people with acne, oh, they eat such bad diets, they should look after themselves better, you know? And that's no one's fault. That's just like a pervasive sort of
judgment,
opinion or judgment. But you know, people with acne have to deal with their acne as well as people's judgments of their acne. So it's emotionally really damaging. Yeah,
and well, salient and caring words, I've got to say, Rebecca. So thank you for joining us on FX Medicine.
Thank you.
Cheers. This is FX Medicine. I'm Andrew Whitfield Cook. Registrations are now open for the Acne conference to be held in Melbourne on the 5th and 6th of May 2018. Joining us today is Dr. Christabel Yeo, President of Acne and Conference Chair. Welcome, Christabel. What can you tell us about the conference this year?
Hi, Andrew. So this year our conference title is Health for Life, Mastering the Integrated Approach. And our conference program is going to highlight 3 key areas of nutritional medicine practice, which is metabolism, gut immune axis, and healthy aging.
And of course, that's going to be covering a wide expanse of conditions and interventions. So what can you tell us about the various aspects of these? For instance, genes, gut, nutrition, and the environment, one of the subtitles.
Well, let me tell you a bit about the overall conference, because we've put this together especially for practitioners who are dealing with patients who are not only worried about advancing age and declining cognition, but they also have multiple conditions, and we know that all of this does overlap with the gut immune axis, metabolism, oxidative stress, and essentially healthy aging. So how do we work out their multiple and overlapping risks, triggers, and perpetuating factors, and then so ultimately how do we facilitate the optimum health comes in an integrated biomedical approach. So in these themes, what we are doing is under metabolism, we're going to be talking about fasting mimicking diets, weight gain, mitochondrial disruption or metabolic disruption from heavy metals. And under the gut immune axis, we'll be talking about the oral microbiome, hidden food factors in common gut conditions, things that people haven't particularly thought about. And we'll also talk about the active role of specific food components on intestinal receptors and immunity. And so with healthy aging, we'll be talking quite a lot about genetic influences there, how we integrate genetics, nutritional and environmental approaches for healthy aging, as well as the metabolic aspects of acidosis, and then also the mitochondrial aspects of how the mitochondrial immunity, chronic infection is tied in with healthy aging.
Who will be speaking this year?
Well, we're super excited this year because we have Dr. Robert Roundtree, who is a family medicine practitioner from Colorado and a well-known IFM faculty medical doctor, but really practicing like a naturopathic doctor, like many of us nutritional medicine doctors. And from America, we also have Professor Walter Longo's lead researcher, Sebastian Branhor, speaking about the fasting mimicking diet. And we have, of course, our local favorite researchers like Professor Ross Grant, always talking about our favorite topics like the brain and mitochondria. We've got Professor John Tagg from New Zealand, a microbiology researcher, giving us more depth on the oral microbiome. We've got Professor Joseph Proetto, an endocrinologist from Melbourne, talking about weight management. And then, of course, we really wanted to integrate having clinicians together with our amazing researchers and PhDs. So we have our local fan favorite naturopathic educator, Rachel Arthur. We have Denise Furness talking more about genetics. And on the last afternoon of the session, we really want to make it very practical and very clinically focused. So we have other clinicians like Warren McGinn talking to us, and Nicole Bilsma bringing in some of the environmental aspects.
That's an incredibly impressive lineup you've got. How do people register for this?
So to register for this event, go to conference.acnum.org.